At NIH, our goal is to generate evidence. We don't make policy. We don't tell people what to do. We provide the evidence that says if you do it one way, you're a lot healthier than if you do it the other way.
And now, from San Francisco and the UCSF Rosenman Institute, the Health Technology Podcast with your host, Christine Winoto.
Our guest today is Dr. Diana Bianchi, a renowned leader in maternal and child health. She is the director of the Eunice Kennedy Shriver National Institute of Child Health and Human Development. She also manages a significant annual budget dedicated to pioneering research in human development and reproductive health. Her unique perspective is shaped by her dual focus on obstetrics and pediatrics. As part of her remarkable work in prenatal genomics, Dr. Bianchi has set new standards for diagnosing and treating genetic disorders. Her efforts have impacted countless lives and significantly advanced the understanding of maternal and child health. In this episode, we discuss the surprising state of child and maternal health care, her innovative approaches to improving health outcomes, the critical importance of maternal and postpartum health research, and the programs being developed to address disparities in healthcare. And now, please enjoy our conversation. Thank you, Dr. Bianchi, for joining us this morning.
It's my pleasure, Christine. Thank you so much for inviting me.
Oh, we are looking forward for this conversation, and we're so excited to have you on our podcast to share with our community about the work that you do. But before we start, I always like to start with your journey, your personal journey. How do you choose the path that you chose to be where you are today? And that'll be really exciting to hear.
Well, thank you for that question. I always joke and say I'm the mutation in my family because no one in my immediate family was in medicine or science.
Oh, wow.
But I always had an interest in natural history and finding abandoned animals in the backyard and that sort of thing. But the thing that crystallized my interest in medicine was watching my cat giving birth to her kittens. And it was under my bed, and I just lay on the floor and watched the whole process. And I was either 3 or 4 years old at the time. And that it just left an incredible impression on my mind.
It's impressive.
And then I happened to attend fantastic high school, which was a 6-year program with a very strong science emphasis, and it was all female. There was a very unique atmosphere, and I just loved the science courses. And one of the things we were allowed to do was do a special honors project in our senior year. And I should say that I grew up in Manhattan, in New York City. And I went to work at Roosevelt Hospital, where I learned how to study chromosomes and learned about preparing them and looking under the microscope and counting them and looking for pattern variations in them. And I just thought that was so exciting. And as part of that honors activity, I met 2 female pediatricians who assured me, this was back in 1972, they assured me that women could be doctors too. And prior to that, I really didn't have any direct exposure to female physicians. And that just started it. It lit a match under me in terms of both medicine and doing research, because my research project was to look for abnormalities in the chromosomes in women who had been using heroin. There was a question whether if you used heroin, whether it would break up your chromosomes. It did not, but it was an interesting question to study. And from there, I went to the University of Pennsylvania, where I was able to do more research. They had a medical school and they still do have a medical school right on the campus. And that allowed many opportunities to do research. But I continued with my interest in genetics and worked in some of both the clinical and the research laboratories in the summer. And from there, it was a jump to medical school, which was relatively straightforward. I ended up going to Stanford because I wanted to be on the West Coast and have a different experience from West Philadelphia. It was there that I really could not decide between obstetrics and gynecology and pediatrics. And what ultimately led to my decision to train in pediatrics was neonatology and being able to take care of the smallest and most vulnerable of the babies. I was more interested in the babies than the mother. But in fact, throughout my entire career, I have been involved in the care of children, the care of people with genetic conditions. And my research has ended up being largely in prenatal diagnosis. So I've straddled these fields, which I always thought was a disadvantage until I got to my present position. So I was in academia for close to 30 years when I got the call from Dr. Francis Collins, the director of the NIH, inviting me to come to the NIH as the director of the Eunice Kennedy Shriver National Institute of Child Health and Human Development. It was something that was not part of my life plan. I was surprised. I had not really worked in government or interacted with government or even been involved in policy. I was a teacher, I was a clinician, and I was a researcher. But I thought this was an amazing opportunity to give back to the country and really to advocate for the populations that I have served my entire life. That's children, pregnant people, people with intellectual disabilities.
Well, thank you for sharing that. You mentioned earlier where you said that before this position, the fact that you're straddling trying to take care of the baby, the mother, why is that a disadvantage? You don't think that was an advantage, that it was giving you a hard time?
Well, I think that it's very important to think in a multidisciplinary fashion, but in terms of career progression in academic medical centers, it's still fairly siloed, where you have a primary career path, let's say in pediatrics, and you're identified as a pediatrician. You may not necessarily have the same ability to progress along the ranks if you have a secondary specialty. So it's pretty siloed. Whereas again, particularly at my institute, which is referred to as NICHD. If I talk about NICHD, that's the institute. We are very broad in covering these different areas. And we recognize now how interconnected the mother, the placenta, and the baby are. And you have to have a healthy mom to have a healthy baby.
Right. And so now going towards to your current position, tell us a little bit more about what is the mission and the goal of the institute that you're running.
Yeah, so our mission is really to be the leader in research and training to understand reproductive biology and health, to improve the care of children and adolescents, and to optimize abilities for all. So that means that people with intellectual disabilities and physical disabilities, we do research to help them on a daily basis.
And what type of research are being supported by the institute?
There's quite a lot. We have 12 branches, for example, in our extramural part of the institute. So what people don't realize is that if you are in the Washington, D.C. area, the NIH is like an enormous college campus. There are 20,000 people who work there, and they're doing research in their own laboratories, but they're also promoting the science for people in outside universities like the UCSF, for example, which is a major recipient of NIH funds. So in our intramural program, we have about 60 senior investigators who are conducting their own research. Could be very basic research with, for example, zebrafish as a model animal. Zebrafish, believe it or not, we share a lot of genes with zebrafish. And you can have a fish tank in front of you and watch how they develop. And a lot of the genes that are being activated are exactly the same as you and I. So our internal research is going from basic research to clinical research, where we bring patients from all over the country, all over the world, who come to the NIH for studies and for unique treatment. We say first in man type of treatment. And all of that is done at no cost to the person or their family. I think most people don't realize that when they pay their taxes, they are paying for the care of people with these conditions. And ultimately, not only are we helping those patients, but we are advancing knowledge to help people all over the world. So that's the internal part of the Institute. The external part, we've got 12 different branches that span everything from basic development in animals and humans. We fund contraception research, pregnancy-related research, child trauma and critical care research, pediatric growth and nutrition. I'm going to have to think about the other 6, but gynecological health and disease, fertility and infertility. You get the drift. So it's covering a large swath of different areas that affect primarily children and people of reproductive age.
And so many of them, like you provide grant to the university researcher. Do you also provide grant to private sectors who develop certain technology?
Absolutely. Yes. When I spoke with young entrepreneurs at a Forbes 50 over 50 conference this past March in Abu Dhabi, I was surprised at how few, if any, of the entrepreneurs knew of our small business grants. So these are fantastic opportunities for entrepreneurs who are starting up companies. And each of the 27 institutes at NIH have their own programs. We are clearly looking for technologies that improve the health of newborns or do a better job of screening for a pregnancy complication, or are creating ways of assisting people with physical disabilities. And those grants are given in 2 phases. There's, relatively modest, but not so modest, on the order of approximately $200,000 for the initial phase. But if the milestones are met and the milestones are successful, then there's the capability of going on to phase 2 funding, which is in the millions of dollars. And most people don't know about these. So if you just Google SBIR NIH, there are descriptions of these programs, and they're quite frankly underutilized. So they're not as competitive, for example, as other types of NIH grants.
Tell us a bit why it's important to provide this sort of funding to the private sector.
Well, Congress has made it a rule or regulation that we have to use a certain percentage of our overall budget. And by the way, our budget, we're in the middle of the institutes at NIH, but our budget is $1.75 billion. It took me a long time coming from the university to say the word billion. But we have to spend approximately 3 to 4% on these business grants. And Congress thought that this would be a really good way of stimulating innovation in the United States. So we're required to spend that money, and that's why I say it's frequently underutilized.
Do you know why that compared to, is it because of the particular areas rather than the oncology space that maybe everybody knows about it?
Well, I think if you have a certain amount of venture funding, you don't qualify for one thing. But I think the bigger problem is many people don't know about it. So they don't know about this opportunity. So I'm hoping that perhaps if even one person learns about it from the podcast, that would be great.
Yeah. So one of the things that oftentimes, definitely we hear a lot more now is that the disparity, the inequality in terms of the maternal health. There's a lot of mention on the newspaper these days about mortality rate for pregnant women, different socioeconomic. Is there an area that I'm sure that you're looking into it, but what are the things that you guys do to kind of change that?
Yeah, so that's a great question, Christine. You're absolutely right. Maternal mortality and serious health complications for pregnant people, that is very much in the center of our interests and our portfolio. We are co-leading a $30 million initiative called the Improve Initiative, which is implementing a maternal health and pregnancy outcomes vision for everyone. It encompasses the work of multiple different groups at NIH, but I think your audience would be interested in the technology challenge. So there's a big problem with pregnant women living in rural areas. So there are as many as there are millions of women who don't have access to obstetrical care. And if they do, they have to drive several hours. And we know from studies that NICHD has funded that if you're living in a rural area, you are 3 times as likely to die than someone who's living in San Francisco who has access to care. Not specifically San Francisco, but an urban area with multiple hospitals and adequately trained specialists. So if you're in a rural area, what do? How do you know if you need to drive 3 hours to get care? So it's a major gap to have technology that can recognize women who are at high risk of having a stroke because they have enormously high blood pressure, or they're bleeding, but their level of anemia is getting to a critical point. Or how do we screen for women who have very serious postpartum depression? So these are all areas in which we have an ongoing challenge to develop technologies. And it's done a little bit like the Shark Tank. So we started out with many, many proposals, and then they have been reviewed, and gradually we're now down to the 10 finalists who have different technologies that are all being developed to recognize complications for women who do not have easy access to obstetric care. So that's one thing we're doing. Another thing we're doing is really listening to the lived experience of people in the community. As I was training, it was always a very top-down exercise to decide. The investigator would decide, here's a problem that needs investigating. Was that a need in a particular community? The community was never involved. And certainly with the pandemic and with the death of George Floyd and the gradual realization that we really need to listen to people who've had very different experiences from you and I. I think it hit me when we were doing a tribal consultation, because not only Black African-American women, but Native American women, American Indian women, and Alaska Native women all have elevated risks of dying during pregnancy or in the 1 year postpartum. So we were doing a tribal consultation with multiple different tribes on Zoom to listen to them and to understand what is their biggest need. And what really struck me was when one of the tribal representatives from the Navajo Nation in Arizona said, it's not that we don't have access to care. We don't have access to fresh food. And for us to get fruits and vegetables, we have to drive enormous distances, sometimes 3 hours. And we don't all have the capacity to do that. So we are limited in terms of the kind of nutrition that we can get. So that's an example of really factoring in the community experience and what the community wants. I personally would not have thought that would be a problem, but that's because I didn't grow up in that kind of environment. So we need to hear from the people who are directly affected. Also, as part of this Improve initiative, we are working with electronic health record data to try to understand certain biomarkers. When should we be worried at the beginning of a pregnancy that this woman is going to have complications? And I should say, I say woman, but I also mean pregnant people and birthing people. We are very inclusive in our studies. We recognize that not everyone who is going to give birth to a child necessarily identifies as a woman, but I'm going to say woman for shorthand.
You mentioned a few things that, we hear about the rural care access to the practitioner, and you have to drive 3 hours. I remember when I was pregnant, the frequency of me seeing a doctor is a lot, right? You have to get tested and you do all this, and I have a very easy pregnancy. And for somebody who drives 3 hours every time, I probably don't want to do that. And is one of the things that we hear a lot is that, well, the telehealth can support a lot of that work, but oftentimes there's no broadband. And so almost feel like, okay, we do all this technology, but there's this infrastructure that need to happen. That's one thing about the rural health. And we're talking about also the nutritional food. And the thing you mentioned about, you have to drive 3 hours to get good nutritional grocery store. I listened recently, somebody told me that in Chicago, the city of Chicago is putting together a grocery store for, I don't know if you heard that. It was just somebody mentioned that to me. The city of Chicago is trying to address that.
Well, nutrition, we recognize that nutrition is critical for overall health, to reduce obesity, which is associated with so many complications. And I think your point about Chicago is very important, because I didn't want to imply that this is only an issue in rural settings, although from the perspective of maternal mortality, if you're living in a rural setting, you're in a high-risk situation. So I applaud the city of Chicago. It seems like this is not such a difficult thing to do, but we need an overall recognition that good nutrition helps with the baby's development. It prevents obesity in the mother and ultimately in the child. And there's so many complications that are secondary to obesity. There's virtually an epidemic now of type 2 diabetes. And when I was a resident in pediatrics, it was so unusual to see an obese child. And now it is quite common. And, an increased focus on nutrition is extremely important. There is an office of nutrition research at the NIH. It's not in my institute, but there is a big emphasis on healthy nutrition and understanding, again, the importance of community in promoting a culture of healthy nutrition.
It's sometimes we take food for granted because I feel like it's almost, because eating healthy food is almost like the preventive care part of it.
It is. Food as medicine. That is a very important concept.
And so I think, the world, everybody get busier, then people have less time to to be able to cook, and people have multiple jobs, and sometimes easier said than done to have a healthier food. And I think, growing up, I grew up in Indonesia, where every day we have fresh vegetables, fresh fish. People go to the market every day. Here, people don't. And how do we tackle that? Because oftentimes when you go to get a healthcare, you got your Medicaid, you got your insurance to help pay for your care. But when it comes to food, it's all on us. Yet it's an important piece.
Yeah. Well, so again, we can address it at the NIH by research. And really, I should mention that at NIH, our goal is to generate evidence. We don't make policy. We don't tell people what to do. We provide the evidence that says if you do it one way, you're a lot healthier than if you do it the other way. And then we share that information with professional societies who then communicate. And, members of Congress pay attention as well. And they will also make policy that will promote health. But there's still a lot of work to be done. There's one big research project called the All of Us program, which is aiming to enroll close to 1 million people with overrepresentation of underrepresented minority groups. And you give access to your electronic health record, you give a blood sample, they weigh you, they measure your abdominal circumference, and then you're given the opportunity to participate in multiple studies. And so there's a precision nutrition study that is enrolling people, that is giving people the opportunity to have short periods on different diets. So like the Mediterranean diet, a low salt diet, a low carb diet, and then they use the information with blood tests to determine what is the best diet for you. That's why it's called precision nutrition, because there's a lot of conflicting information out there. You shouldn't eat eggs. You should eat eggs. Eggs have a lot of vitamins. No, eggs are bad for you. That would be one example. But the goal of this precision nutrition study is to really determine what's best for you as an individual.
And do you think that is different per individual based on their genetic makeup, based on their race?
Yes. I mean, it should be. Your underlying genetics, your exposures in the womb, what your mother and your grandmother ate influences your metabolism. Even brothers and sisters might be different because they have 50% of the same genes, but not 100% of the same genes. They were in the womb at different times in their mother's pregnancies, so their reactions might be completely different. So there's an overall emphasis nowadays on personalized or precision medicine, with the understanding that one size doesn't fit all. And, you might be given amoxicillin for an infection, but maybe that's not the best drug for you. Maybe there's another drug that would work better with your body to treat an infection.
Now I'm starting back to the mother side, the maternal health side. One of the things that I hear a lot is about the access to doula can be helpful in the space of maternal health. And that was, at least when I first heard it, it surprised me, because when I think about getting pregnant, having delivery, you go to see the doctor, but not so much with the doula. What are the research in the doula space to help increase maternal health?
Yeah, so there aren't enough obstetricians in the country right now to treat all pregnant people. Furthermore, we kind of talked about maternity deserts where there isn't an access to an obstetrician. It's getting worse in certain states. So in states that have more restrictive laws now related to reproductive care, it's been shown that the qualified providers are moving out of the state. The New York Times a few weeks ago had an article about the high-risk specialists from Idaho who are moving out of state. So, for example, women in Idaho have an even more difficult time getting access to care. So there's a tremendous need for care providers who are not necessarily physicians. Furthermore, doulas and nurse midwives may be much more involved in the community, may be more familiar with cultural or specific practices that are important to that community. So as part of this $30 million Improve initiative, we have several groups that are looking at how do doulas affect care? Should they be used more widely? What are they providing? And if we have two groups, one which had a doula involved in their care, one which didn't, do we see differences? The thing about the doulas is that they are with the pregnant person through their labor, and they are also coming to the home after delivery. And that people don't recognize how vulnerable the postpartum woman is. 60% of maternal deaths occur in the whole year after delivery for a variety of reasons. So the emphasis has always been on pregnancy and labor and delivery, thinking that those are very high-risk times, which they are, but they're really collectively not as risky as the postpartum period. So doulas are coming to the home, or nurse midwives are coming to the home and are able to assess how is the mother doing? How is breastfeeding going? Is there excess bleeding? How is the family adjusting to the addition? And, doctors, I can say that being a doctor myself, we do not go to the home. We expect the patient to come to us. So they're getting a whole different perspective on the patient and her environment. And they are trained to alert someone, to intervene. We have a very medicalized system in the United States of pregnancy, labor, delivery. We have a very high rate of cesarean section deliveries, for example. And that's in contrast to the Netherlands, for example, which is obviously a very well-developed country with a high socioeconomic status. Almost all of their deliveries are done by midwives at the home. Very few deliveries are done in a hospital setting. And their rates of maternal mortality are quite a bit lower than ours.
I'm surprised that with a lot of education talking about C-section, how it is a riskier path to deliver a baby and it's still high, I thought that would come down rather than staying high, even higher.
We have one of the highest rates of maternal mortality in the developed world. So amongst our peer countries economically, we are one of the worst. And it continues to rise. We saw an increase as a result of COVID, but it's still increasingly rising. And, there are other social determinants of health and disease. It's become more apparent that there is racism in the obstetrics setting, and there's intergenerational racism as well, which increases stress and is associated with adverse outcomes. So these are other things that we're trying to address because we want to make the United States the safest place to give birth. We have a long way to go.
Mm-hmm. I think oftentimes when we think about United States, we think we are such a developed country. We are the first on many different fronts. And when you see the statistic number and the maternal health and mortality rate for pregnant women, it's very startling to see. And I know we are short on time. I feel like there's a lot more that I want to ask you, but one thing that I always ask our guests lately that I know is kind of a bit off topic from what we've been talking about. What are the best advice that you got, especially when you're joining, when you got a call from NIH to lead this institute? I'm sure either you still got a lot of advice or people give you a lot of advice.
Well, one particular piece of advice that I remember, because it's a very different job, and I know that you have some young people who are considering multiple different careers in healthcare or research. The NIH has a tremendous number of opportunities to shape science and to get involved in research. So I would advise people to go to the website, but it's a very different environment and a very different job from being a professor, which I was very familiar with. When I arrived, I wrote a blog piece that was called Entering the Land of NIH, because in a way it was like entering a different country. The campus is under high security. You enter with airport level security. And once I got here, people were speaking different language. They were just, the emphasis was a bit different from academia. But Dr. Fauci was great with mentorship. And the one thing I remember he said to me was, it's going to take you 3 years to understand this job. And he was absolutely correct. The other thing is, a unique aspect of this job, which I totally appreciate, is the opportunity to speak directly to congressional representatives. And, whether they're red or blue, I think that they are genuinely interested in improving the health of their constituents. And for the most part, they listen, and their staff and they themselves are very well informed. So that leads to, in general, a very stimulating conversation, and hopefully we can inform them about the importance of our portfolios. But I got a lot of advice about how to handle those situations, because professionally I had never had to testify, but it's an incredible privilege. And this is an amazing job because it's the opportunity to really help so many people.
Okay. Well, thank you for your time and share your insight. Before I end, one of the highest cause of death in this country is gun violence for children. I felt very strongly about it, but also it's very complicated. Is there a role for NIH in trying to address this?
There was a time when Congress would not allow us to fund research in this area, but more recently, we were given money to address this question. So I mentioned earlier that we do have a branch in pediatric trauma and critical illness, and they are funding research in gun violence, which is the leading cause of death for children. And we absolutely need to understand the best ways to prevent this. Also to understand the effects that the violence has, not the direct health effects, but the secondary consequences for children in classrooms, for example, who survive. What happens to them? So, yes, it is an area that we are studying. We're not taking a political position on whether guns should be available or not. We are really looking at safety issues, prevention issues, and how we can improve the health of people who are exposed to gun violence.
Yeah, I mean, I was one of the things that I never thought in my life that I know somebody personally who are affected by gun violence. I always think that, well, sometimes you read on the newspaper, that's something that you don't know somebody, that person. And I thought that's very poignant and very, it's making you think twice or 3 times to think how lucky we are. But one of the things I also hear from one of my friends who is in the insurance industry, and she was telling me that now they have a product on their insurance plan to cover in case you are affected by gun violence. And I thought that was really, we have a health insurance, we have auto insurance, fire insurance. Now you have the gun violence insurance.
Well, this is news to me, but it just shows you how common the problem must be if they're giving a special product associated with insurance.
Yeah. So, well, thank you for your work. Looking forward to see a lot of the work that you and your team member accomplish, and hopefully things are moving the right direction with all the work that you do.
Thank you. And I thank you again for inviting me. And I do want to emphasize that the public-private partnerships are very important to us as well. And that's why I mentioned the small business grants. But we've also been able to accomplish some amazing things with the partnership of the Bill and Melinda Gates Foundation or the partnership with industry. And that is something that I've really taken advantage of in my career. And so I'm hoping that, entrepreneurs who are particularly interested in pediatrics or maternal health will be listening and will be thinking about our institute.
Thank you for tuning into today's episode of the Health Technology Podcast. We hope you found the conversation insightful and inspiring. If you enjoyed this episode, please take a moment to subscribe, rate, and leave a review on your favorite podcast platform. Your feedback helps us continue bringing you the latest in health innovation. Stay connected with us on LinkedIn and Twitter for updates on upcoming episodes and more. Until next time, keep pushing the boundaries of what's possible in healthcare. I'm Christine Minato, and thank you for listening.